Neonatology Forum Kerala, IAP Thrissur and FNNF Thrissur.
To begin with, we have a 45-minute session, Oxygenation in Neonatal Lung Injury. We are much grateful to have with us Professor Satyan Lakshminrusimha as the speaker, who will be joining us online. To moderate the session, we have Dr. Srinivas A.R.
Dr. A.R. Srinivas, Head of Department Neonatal Services, Kovai Medical Center, Coimbatore. With about 20 plus years of clinical practice in various countries, including Australia. His special interests include non-invasive ventilation and neonatal sepsis. It's our great privilege to welcome you here, sir.
Thank you very much. Good morning to everyone. A warm and pleasant day and a rainy day today. I hope you had a nice walk. Just to start with, today we will be having another day filled with lot of feasts of knowledge. The first lecture is going to be given by none other than Dr. Satyan Lakshminrusimha. I know him from college days. He was my colleague during MD. He was extraordinary even during those times. All his seminar presentations would be filled with exemplary knowledge and illustrations. And then he was a gold medalist in the MD, and then subsequently he got a fellowship in US, and once he reached US, there was no way to stop him. He had a lot of researchers, and then was working as a consultant in Buffalo Hospital. And then from then on, because of his hard work, he got a very high post, that is chair of pediatrics in University of California. And it's not so easy to get a job like that with competing with the local legends there. And now he's doing an excellent job. And today we request him to deliver a talk on how to protect the lungs from oxygen. Thank you.
Thank you, Srinivas, for a kind introduction. Can you hear me? Srinivas, can you hear me?
Yeah, I can hear you.
Okay, great. It's an honor to be part of this session and share the podium with Dr. Ram. And it's so nice to be introduced by you. It's good to be among classmates again. Thank you so much. So as Srinivas said, I'll be talking today about optimal oxygenation in neonatal lung injury, mainly focusing on optimal saturations and what we should target when we're dealing with babies with neonatal lung injury. If you have any questions about this presentation, please email me. Here is my email address and here is my Twitter account, and happy to follow you back and discuss these issues with you. So I don't have any disclosures. I won't be talking about any unapproved or off-label investigational drugs. I have no conflicts of interest. So we'll address briefly resuscitation in term infants, talk about preterm infants and oxygenation, and deal the bulk of the talk on term neonates with lung injury and pulmonary hypertension of the newborn. So the controversy we have here is as to how much oxygen we should give, whether babies should receive low oxygen or high oxygen. And unfortunately, both of these have problems of their own. The problem that we deal with on a daily basis is that we do not have clear-cut diagnostic criteria for hypoxemia or hyperoxemia. There is no absolute PaO2 or pulse oximetry oxygen saturation below which we can comfortably say that hypoxemia happens across the age spectrum. And same thing applies to hyperoxemia as well. So we often divide or define these entities based on the diseases that might occur due to lack of oxygen, which mainly includes pulmonary hypertension, necrotizing enterocolitis, mortality, and in some cases, periventricular leukomalacia. On the other hand, hyperoxemia is defined by entities that can be harmed by excess oxygen, mainly retinopathy of prematurity in preterm infants, and also bronchopulmonary dysplasia in preterm infants. As you can see here, there is no clear-cut entity associated with hyperoxemia in term infants. And that's part of the problem that we face in dealing with oxygen saturation targets. So why does this matter? This all goes back to physiology, and this is a classic paper a few decades ago by Peters and colleagues, where they took fetal lambs and adjusted the amount of oxygen content in the blood in the fetal lambs, and they looked at what would happen to blood flow to various organs. So this red bar that you see is the normal amount of oxygen present in the fetus. Remember, fetuses are relatively hypoxemic compared to postnatal children and adults. So they carry approximately 10 ml per deciliter of blood of oxygen in their blood. And when the oxygen level goes down in the blood, you see an increase in blood flow, a compensatory increase in blood flow to three organs: the brainstem, myocardium, and the adrenals. On the other hand, when blood oxygen content decreases, a reverse phenomenon occurs in kidney and gut where the blood flow goes down. The lungs are unique in that if you give them more oxygen, they tend to dilate and have pulmonary vasodilation. So oxygen induces pulmonary vasodilation in the lungs. Interestingly, the placenta, which is like the mother, irrespective of the oxygen content, continues to deliver the same amount of blood flow to the fetus for the most part, unless the mother gets really sick. So the fetal blood oxygen content really does not influence placental flow to any substantial extent. So based on this particular picture, Dr. Smith, way back approximately 50 years ago, classified organs as non-negotiable, which is the adrenals, myocardium, and the brain; negotiable, which is liver, gut, and kidney; and expendable, the bone, muscle, and skin. So this is a better terminology than using the words essential and non-essential to describe these organs. So what are the physiological consequences of this? So many of you are familiar with this curve where oxygen delivery is shown on the horizontal axis and oxygen consumption is shown on the vertical axis. Normally in you and I, we deliver close to 4 times more oxygen than the body really needs. So we are way here on the spectrum. So as the oxygen delivery keeps on going down, in the initial part, even though the oxygen delivery decreases, there is no impact on oxygen consumption. And this portion of the curve, this flat portion here, is the delivery independent oxygen consumption. On the other hand, when oxygen delivery falls below a critical point, then with decrease in oxygen delivery, there is decrease in oxygen consumption. And this portion of the curve, the blue line here, is called as the delivery dependent oxygen consumption. Unfortunately, it's not very easy to define this critical point on a day-to-day basis on the clinical side. And so for that reason, we use many other factors such as lactic acidosis to define when we go below the critical point. So how do we define the lower and upper limits here? The upper limit is defined by oxygen toxicity, mainly by ROP and BPD in preterm infants. But in term infants, as I mentioned before, there is no clear-cut disease associated with hyperoxemia that we know of at this time. But on the other hand, you do produce substantially more number of reactive oxygen species when you expose them to hyperoxia. And one of the effects, as I will show you in future slides, is to reduce the effectiveness of inhaled nitric oxide because of production of superoxide anions. What about the lower limit? The lower limit in postnatal life is fairly clear-cut by manifesting in 2 forms. One is tissue hypoxia that results in lactic acidosis, and the second is hypoxic pulmonary vasoconstriction. As I mentioned to you before, oxygen causes pulmonary vasodilation, and lack of oxygen causes pulmonary vasoconstriction. And this vasoconstriction can be used as the lower limit for optimal oxygenation of a baby in an NICU. Interestingly, as I showed you in the previous curve, in both control lambs and lambs with asphyxia, reducing the arterial oxygen content in the blood in the carotid artery results in an increase in cerebral blood flow. So there is not only an increase in cerebral blood flow, there is also an increase in oxygen extraction. So hypoxia causes cerebral vasodilation and hyperoxia causes cerebral vasoconstriction. this is exactly the opposite of what happens in the lung. What's the clinical relevance of this? So for example, let's say you have a baby with perinatal acidosis. You bring the baby to the NICU and you get a first arterial blood gas on the baby. If that baby's first arterial blood gas has normal PO2, then the risk of hypoxic ischemic encephalopathy or HIE in that baby is low, somewhere between 22 to 27%. On the other hand, if the first arterial blood gas has a PO2 more than 100, especially if it's higher and higher, the risk of HIE is much more higher. It can be as high as 89% when the PaO2 levels are more than 231 millimeters of mercury, which goes to show that a combination of perinatal acidosis or asphyxia with postnatal hyperoxia increases the risk of HIE in these babies. So it's really important. We can't really say that whether this is causation or really a effect or just an association, but this is something that we should remember. When you bring a baby after resuscitation to the NICU, you should try to maintain normal SATs and avoid having hyperoxemia in these babies. As opposite to what you saw in the brain, you see exactly the opposite in the lung, where if you reduce the PaO2 level, you start seeing a drop in pulmonary blood flow. And this is what is called as hypoxic pulmonary vasoconstriction. And there's a change point when this occurs. And this change point in this particular series in lambs was approximately around 50 millimeters of mercury. So if you maintain the PaO2 above 50, the blood flow to the lung is normal. When then the PaO2 goes below 50, especially when it goes really low, you start seeing a precipitous drop in pulmonary blood flow due to hypoxic pulmonary vasoconstriction, exactly the opposite of what happens in the brain that you saw in the previous slide, in this slide. So every day that you work in the NICU, you and I are walking a tightrope balance. We are trying to balance between hypercarbia and hypoxemia that results in low pulmonary blood flow resulting in pulmonary hypertension, reduced splanchnic blood flow resulting in necrotizing enterocolitis and mesenteric ischemia and sometimes death. On the other hand, hypocarbia and hyperoxia decreases cerebral blood flow and in turn can also reduce retinal blood flow and cause retinopathy or prematurity. So optimal oxygenation is a delicate balance between cerebral or retinal and pulmonary or splanchnic vascular reactivity. And you and I conduct this delicate balance on a daily basis when you're around in the NICU. The other complex phenomenon here is that when you have a baby with pulmonary hypertension or say meconium aspiration with hypoxemic respiratory failure, you're dealing with two very interesting entities. One, the baby is on very high O2, so you're exposing the lung to hyperoxia. So you have alveolar hyperoxia. On the other hand, the body is having hypoxemia, and so you're subjecting the body to systemic hypoxia. Interestingly, both systemic hypoxia and alveolar hyperoxia can both induce the formation of reactive oxygen species in a different mechanism and can have various effects because of that, not only short-term effects, such as acute respiratory deterioration and hypotension, but also long-term conditions such as bronchopulmonary dysplasia and chronic lung disease. So let's see what we should do during resuscitation of term infants briefly. So as many of you know, a fetal PaO2 level is very low, and this is somewhere in the 25 millimeters of mercury to 30 millimeters of mercury range. And even increasing the PaO2 to somewhere around 50 with 21% O2 when the babies breathe room air induces a bit of oxidative stress as seen by the pink shaded area down here. On the other hand, if you expose the same baby at term, even briefly to 100% O2, it induces a much larger free radical formation. And Professor Max Vento from Spain has shown that this brief exposure of 100% O2 can result in free radicals in the urine as long as 28 days after birth. So this damage can be prolonged due to oxygen-free radicals. So exposure to 100% O2 can cause brain inflammation, increased incidence of HIE, as I showed you earlier, myocardial damage, acute renal injury, and in epidemiological studies has been associated with childhood leukemia and increased mortality in babies. So exposing term infants to 100% O2 is definitely not good. And both the NRP and the ILCOR clearly suggest that in term infants, we should initiate resuscitation with 21% oxygen. But that clearly don't tell us what we should do when you have a baby with pre-existing pulmonary hypertension. Say, for example, a baby being delivered with congenital diaphragmatic hernia. So what do you do in babies with congenital diaphragmatic hernia? In addition to avoiding bag mask ventilation and doing oral gastric tube to suction and intubation if needed, one thing to consider is to do delayed cord clamping, because remember, the placenta is the only source of fetal hemoglobin. You can't get fetal hemoglobin in any blood bank. So getting some blood out of the placenta into the baby is really vital when you expect PPHN in these infants. So once that's done, how much O2 do you give these babies in the delivery room? Traditionally, many of us for many years, any baby with PPHN, we have used 100% O2 in the delivery room. But recent data from CHOP, Children's Hospital of Philadelphia, suggests that you can probably get away with using 50% O2 in these babies, as long as the SATs are reasonable. So what does that protocol look like? So for babies with PPHN, especially congenital diaphragmatic hernia, they initiate ventilation with 50% oxygen. And then after 30 seconds, if the baby is still bradycardic, then they go to 100% O2. If not, they continue with 50% oxygen, check pulse ox at 5 minutes of life. And if the SATs are less than 80, then they go increase the O2 gradually by 10% till the SATs go above 85%. On the other hand, if the SATs are more than 80% by 5 minutes, they continue with 50% oxygen. Why is this important? A diaphragmatic hernia baby who does not tolerate 50% O2 and requires 100% oxygen has a much higher mortality of 31% compared to babies who can be managed just with 50% O2, where the mortality is only 5.1%. So the need for high O2 in a baby with diaphragmatic hernia is an indication of pulmonary hypoplasia and pulmonary hypertension, which puts these babies at a much higher risk for high mortality compared to babies that can be managed with traditional O2 around 50%. So even when you suspect babies with pulmonary hypertension and diaphragmatic hernia, for the most part, you can get away. See here, 61 babies could be managed with 50% O2. Only 7 of them required 100% O2. So it's important to realize that you can initiate at least initial ventilation with 50% O2 in these babies, and there is no reason you need to resort to 100% O2 routinely. Experimentally, how can we show that 50% O2 is equally effective? This is a study that me and my colleagues did way back around almost 14, 15 years ago, where we took a bunch of control lambs and a bunch of PPHN lambs where we ligated the ductus to create pulmonary hypertension during fetal life. And as you can see here, lambs with PPHN have approximately 6 times higher pulmonary vascular resistance compared to control lambs. Then these lambs were ventilated with 21% O2 shown in green, 50% O2 shown in orange, or 100% O2 shown in red. As you can see here, giving 100% O2 does result in more pulmonary vasodilation initially for the first few minutes. Same thing happens in control lambs as well. But by the time you get to 30 minutes of life, there is no difference between 50% O2 and 100% O2. Both of them cause same degree of vasodilation. And in fact, interestingly, even 21% O2 is not statistically different from these numbers. So optimal ventilation and increasing alveolar oxygen is probably more important than achieving a high PaO2 in these lambs. So ventilation is the key to newborn resuscitation, and optimal oxygenation is also required, but you can achieve that with much lower O2 than 100% O2 in lambs with PPHN. The negative aspect of using 100% is that following that experiment, when the same groups of lambs with PPHN were given inhaled nitric oxide, the lambs that had received 21% O2 initially for resuscitation had profound drop in pulmonary vascular resistance, a great response to inhaled nitric oxide by almost a 40% decrease in their PVR. On the other hand, giving 50% O2 had the PVR decreased only by around 35 to 40%. Not bad, not different from 21% O2, but those lambs that were received 100% O2 at birth had a much lower decrease in PVR at birth, only around 25%. So this goes to show that initiation of resuscitation with room air results in better response to pulmonary vasodilators later in the NICU, and the response to 50% is also fairly similar. On the other hand, high exposure to oxygen, especially 100% in the delivery room, results in poor response to inhaled pulmonary vasodilators such as nitric oxide, And this is thought to be due to a superoxide-mediated inactivation of nitric oxide cyclic GMP pathway. So do we have any evidence that giving 100% O2 in the delivery room results in superoxide anion formation? So we looked at that next. Here is one of my colleagues, Ms. Silvia Gugino, who looked at the sections from these lamps that had received 21% O2 for resuscitation for just 30 minutes, and then stained them for superoxide ions. Whatever red you see here is superoxide anions. Here is the airway, here is the pulmonary artery. As you can see here, giving 21% O2 hardly elicits any superoxide anion formation in pulmonary arterial smooth muscle cells. On the other hand, giving 100% O2 for a brief period of 30 minutes lights up the whole pulmonary arterial smooth muscle cells, resulting in abundant superoxide anion formation. And these superoxide anions can easily inactivate inhaled nitric oxide. So what about preterm infants? This is one thing that has been studied very, very well in neonatology, and one of the best groups of randomized controlled trials done with close to 5,000 babies enrolled. And the question that they asked in these NeoProm trials was, what is the optimal target SpO2 for preterm neonates that would result in decrease in death or neurodisability? And the randomized babies in US, Canada, UK, Australia, and New Zealand, and published in prominent journals, New England Journal of Medicine and JAMA. And the randomized babies to 85 to 89% saturation target or 91 to 95% saturation target. And interestingly, the combined result of death and neurodisability was not different between the two groups. 53.5% in the low target group and 51.6% in the high target group. But there were very interesting secondary outcomes. The low target group had higher incidence of necrotizing enterocolitis, higher mortality, and higher need for PDA surgical ligation. On the other hand, babies randomized to the higher target group had increased ROP, although there was no change in blindness, and increased need for supplemental oxygen at 36 weeks post-menstrual age, what we define as BPD colloquially. So based on these results, the NeoProm individual patient meta-analysis concluded that there was really no difference between the two for combined outcomes, but the lower SpO2 target range was associated with a higher risk of death and necrotizing enterocolitis, but a lower risk of retinopathy or prematurity treatment. And this was the conclusion of this trial. Based on this, many units all over the world changed their oxygen targets from the high 80s to low 90s in many of these units. Whenever I see a baby go through the NICU, I often compare that to a journey by a car across a road. If this is birth and this is discharge from the NICU, this journey can be characterized by a lane in which the baby is supposed to maintain. And this lane is the target for your oxygen saturation. So the wider the lane, it's easier for the car to stay within the lane. So if you use a very tight, narrow target range, say like you say 92 to 94, it's very difficult to maintain the baby in that narrow target range. On the other hand, if the target is wider, say 90 to 97%, it's much easier to maintain the baby within this target. In addition to target, you can assess this by either pulse oximetry or periodic blood gases, but for the most part, we have become very reliant on prerectal pulse oximetry in these babies. The next thing that's really important is the alarm limits. So I compare these to the rumble strips that you see at the end of the road. If you drive on this, it makes a noise and then you realize that you're off the road. And these rumble strips are similar to alarm limits. And knowing the exact alarm limits is really important to avoid having accidents. So alarm limits are important in achieving the target, and these should be appropriately set on the pulse oximeter to make sure we avoid hypoxemia and hyperoxemia. What was the effect of changing targets in the NICUs? One effect that was shown in New Zealand was that there was increased in ROP when they switched from high 80s to low 90s in the oxygen saturation target. The second thing that was observed in Canada and US are two studies which showed that when they went from SATs of 88 to 92 to 90 to 95, they saw a reduction in the incidence of pulmonary hypertension. So this was the incidence of pulmonary hypertension when they were using 88 to 92% targets. And this is the incidence of pulmonary hypertension when they use a target of 90 to 95. So the same thing that we expected earlier. If you use low saturations, you have pulmonary hypertension and NEC. If you use high saturations, you have more ROP. So this balance really proves out to be true in preterm infants. What about term infants? This is where things get a little complicated, but there are several guidelines that tell us what we need to do. The American Heart Association, the American Thoracic Society guidelines say that FiO2 of more than 0.6 or 60% O2 may be ineffective owing to extrapulmonary shunting and may aggravate lung injury. And they recommend oxygen therapy for infants with pulmonary hypertension whose SATs are less than 92%, especially for those with respiratory disease. The European Pulmonary Vascular Disease Network is much more specific, and they specify pre-ductal SpO2 between 91 and 95 when PPHN is suspected or established. And the Canadian European CDH guidelines usually recommend saturations in the low 90s. But the thing to remember is that all these guidelines are expert opinions, and there is absolutely no clinical evidence from randomized controlled trials evaluating any of these claims. And this purely comes from either anecdotal experience or from animal studies. The bigger problem with term infants is that, as I mentioned earlier, term infants do not suffer from ROP, so we can't really define hyperoxia. But we can define hypoxia by evaluating hypoxic pulmonary vasoconstriction. But the upper limit of toxicity is not really well defined, and so often we'll land up looking at response to inhaled nitric oxide as to what oxygen concentration is interfering with response to inhaled nitric oxide in these babies. So the answer to the hypoxic pulmonary vasoconstriction was given to us by Abe Rudolph way back in 1966, more than half a century ago, where he looked at newborn calves, around 9 of them, and checked their pulmonary vascular resistance with different PaO2 values, and came up with the same change point that I showed you in lambs earlier, 45 to 50 millimeters of mercury. And if you go below that number, you see a huge increase in hypoxic pulmonary vasoconstriction and increase in PVR. But if you maintain PaO2 between 50 and 80 over here, you had low PVR, but increasing the PaO2 above 100 did not result in any additional pulmonary vasodilation. So my conclusion from these studies is that oxygen is a specific pulmonary vasodilator and reduces pulmonary vascular resistance. Hypoxia causes pulmonary vasoconstriction, but normoxia causes pulmonary vasodilation. But hyperoxia, keeping PaO2 above 100, does not cause any additional pulmonary vasodilation, and in fact can cause toxicity. But it's not that simple. He also, Abe Rudolph, in this classic book called Congenital Diseases of the Heart, if you haven't read this book, this is a must read for all neonatologists. What he showed was that when you're acidotic, the change point is higher. On the other hand, when your acidosis starts resolving, the change point keeps on decreasing. In other words, hypoxic pulmonary vasoconstriction does not occur until the PaO2 goes below 30 when the pH is 7.4. On the other hand, when the pH is 7.1, already PVR is much higher, and the hypoxic pulmonary vasoconstriction occurs at a much higher change point. So this change point, the point at which PVR increases, is variable based on acidosis. If you're more acidotic, you tend to have much more intense hypoxic pulmonary vasoconstriction. So recently, my colleague, Dr. Payam Valley, at the Pediatric Academic Society's meeting that concluded last month, showed some data comparing in meconium aspiration syndrome and PPH and lambs, comparing 90 to 94% SATs, which is the blue line here, and 95 to 99% SATs, which is the red line here, and achieved good separation with SpO2 and good separation with PaO2, statistically significant. But what was really striking was that although slightly higher FiO2 was needed, there was absolutely no difference in pulmonary blood flow between low 90s and high 90s, clearly showing that hyperoxia does not cause additional pulmonary vasodilation in these lambs. So when you have babies with pulmonary hypertension, you really, as long as you don't have acidosis, you really don't have any advantage in targeting high 90s for oxygen saturations. So what exactly determines pulmonary vascular resistance? That's a really tough question to answer. But based on animal studies, we know that if you assume this to be the heart, this to be the pulmonary artery, and here is the alveolus, and here is the pulmonary vein, this precapillary pulmonary arteriole, this is the site where hypoxic pulmonary vasoconstriction is analyzed and determined. So the PaO2 at this site is determined by two factors. One, the allular P uppercase AO2, which is PaO2, determines 2/3 of pulmonary vascular resistance. So giving adequate FiO2 is really important in these babies. The second factor that determines PaO2 is pulmonary arterial PVO2, which determines approximately a third of pulmonary vascular resistance. So if you want to have low pulmonary vascular resistance, you need to not only make sure that the PaO2 and the PVO2 are okay, but also there is adequate alveolar PaO2. And the main determinant of alveolar oxygen is FiO2. So it's important to pay some attention to FiO2 also to achieve adequate pulmonary vasodilation in these patients. So going back to what is said in the ATS and AHA guidelines is that they want us to avoid extreme hyperoxia, FiO2 more than 60%. So it's important to remember that adequate concentration of alveolar oxygen is important for pulmonary vasodilation, but achieving very high alveolar oxygenation with more than 60% O2 is associated with lung oxygen toxicity. And so I usually introduce the term called as sexagenty phobia, which is similar to virginity phobia, which is the fear of 20 for bilirubin. Here, I think we should be afraid. We should think twice when a baby is requiring more than 60% oxygen for maintaining PaO2, because if you use such high FiO2 levels, it probably induce some lung toxicity in these babies. The other thing to remember is that both oxygen and nitric oxide, when used individually, are very powerful pulmonary vasodilators. But when they're used in high concentrations together, you can have formation of superoxide anions, which result in formation of peroxynitrite by combining nitric oxide with superoxide anions. And this peroxynitrite can cause intense pulmonary vasoconstriction. So the marriage between nitric oxide and oxygen can be made in heaven if you use low concentrations of oxygen, and can be made in hell if you use high concentrations of oxygen. This can be shown more elegantly by doing stains for peroxynitrite in the lung. Here are 4 lung specimens from lambs. Here is a lamb that received 100% O2 for 24 hours, no nitric oxide, and you see some degree of peroxynitrite formation in the pulmonary arteries. Here is one that received 100% O2 plus 20 parts per million nitric oxide, where you see abundant formation of peroxynitrite. The pulmonary artery lights up like a neon bulb. Here you give superoxide dismutase to completely remove superoxide anions, and then you see complete loss of signal of peroxynitrite. But since we don't have access to recombinant human superoxide in clinical studies, what we can really do is to ventilate with oxygen and titrate it down to maintain FiO2 below 0.6 if possible, and target PaO2 between 50 and 80 millimeters of mercury with 20 parts per million nitric oxide. So this is something we can do. So we should avoid leaving babies in 100% O2 and 20 parts per million nitric for a long period of time, and instead focus on titrating O2 down once the baby responds to achieve optimal oxygen saturation and optimal PaO2 levels. So again, to show the importance of this combination, this was a study done in Italy where they showed that when you use 80% O2 with nitric oxide, in other words, high oxygen plus nitric oxide, you increase the serum levels of TNF-alpha, an inflammatory component. On the other hand, when you use 45% O2 with nitric oxide, you reduce the TNF-alpha concentrations. In other words, nitric oxide can act as an anti-inflammatory agent when you use it with moderate amount of oxygen, but can be a pro-inflammatory agent when you use it with high concentrations of oxygen. So this is something for you to remember. So for the most part, you should be able to use saturations between 91 and 95% reductal while managing babies with PPHN, except in some conditions. If you have intense acidosis and you have signs of acute pulmonary hypertension on echo, or if the baby is on very low concentrations of inspired oxygen and you have severe signs of pulmonary hypertension on echo, or if you have increasing lactic acid level or decreasing urine output, or when you monitor these babies with near-infrared spectroscopy, you see dropping numbers in cerebral oxygenation. These are conditions where you might need and also hypothermia, which Dr. Ram will talk about in the next talk. In these conditions, you may need to focus on using mid-90s as opposed to low 90s in these conditions. But otherwise, for the most part, you should be able to get away with oxygen saturations in the mid-90s, low 90s. So remember that if your FiO2 is low, you can maintain saturations in the low to mid-90s because the benefit of pulmonary vasodilation exceeds that of oxygen toxicity. On the other hand, if your FiO2 need is very high, try to tolerate PaO2s in the low 90s. As long as the near-infrared spectroscopy is okay, lactate levels are normal and urine output is okay. Because in this situation, when you're using such high concentrations of oxygen toxicity exceeds the risk of hypoxic pulmonary vasoconstriction. So to conclude, use of moderate FiO2 might result in slightly less pulmonary vasodilation, but preserves the effect of nitric oxide. On the other hand, use of high FiO2 results in formation of superoxide anions, which can interfere with the action of nitric oxide by forming peroxynitrate, which can destroy surfactant, cause smooth muscle vasoconstriction, and inflammation. So to conclude, optimal oxygen saturation in lung injury is a complex interplay between hypoxia and hyperoxia. There are no clinical trials evaluating optimal oxygen targets in term infants. We only have data in preterm infants. Targeting a wider range like 97% predictal appears to be prudent. You can actually narrow the range down to 91 to 95% in most circumstances. To reduce lung toxicity, try to minimize the time the baby spends with an FiO2 of more than 0.6. The higher target of 94 to 97% might be needed if you have acidosis or hypothermia, which is covered in the next talk. So the main takeaway point from this study, from this presentation, is that always set an upper alarm limit for pulse ox if the baby is on supplemental oxygen. There is no need for any baby in the unit to have 99 or 100% SATs if the baby is on supplemental oxygen. If the baby is in room air, that's a different story. Do not ignore hemoglobin, especially fetal hemoglobin. Try to preserve hemoglobin by practicing delayed cord clamping and avoid excessive blood draw in these babies because fetal hemoglobin is very valuable. You cannot replace it. Also focus on pH and FiO2 while managing PPHN. We really need multi-center global clinical trials to further study this in babies. So the take-home point is that avoid oxygen saturations of 100 or 99% when on supplemental oxygen, because if you walk through the NICU and if a baby is on supplemental oxygen and the baby is saturating 100%, if you don't do anything about it, that's a serious crime. You should be in the O2 right away. No baby should be saturating 100% O2 on supplemental oxygen in any NICU. One other interesting fact here is that I want to conclude by showing the fact that if a baby is on supplemental oxygen, there is no way for you to tell if the baby is saturating 100% has a PaO2 of 100 or a PaO2 of 350 or 400, unless you do a blood gas. So you should really avoid saturating high up in the 99 to 100% range, because at this range, you can fry your mitochondria and create a lot of reactive oxygen species damage in these babies. So when we became pediatricians, we were taught that children are not small adults. And when you all became neonatologists, you realized that tiny preemies are not small newborn babies. But what appears to be interesting is that when you look at preterm infants, it appears as though saturations in the low 90s is appropriate for them. If you go use saturations in the 80s, you see mesenteric ischemia with necrotizing enterocolitis. Based on animal data, we believe that saturations in the low 90s or mid 90s is adequate in term PPHN babies. There are data to suggest that babies with bronchiolitis in the PICU benefit from having oxygen saturations in the low 90s as compared to high 90s. And all of us are getting old here. And there are plenty of studies in adults which clearly show that both for ST segment elevation myocardial infarction and acute respiratory distress syndrome, saturations in the low 90s is better than having SATs of 100% when you have these conditions. But having SATs in the 80s can result in mesenteric ischemia. So across the age spectrum, although there are so many physiological differences, maintaining SATs in the low 90s appears to be prudent for most conditions, if not all conditions, throughout our age. With that, I would like to stop this talk. And again, here is my email if you have any questions, and here is my Twitter account. And I thank you for your attention.
Excuse me, sir. Sorry to interrupt you. We have 5 more minutes to end this session.
Okay. Satyan, that was another excellent talk and very informative. And this was really highlighting about use of oxygen in the neonatal resuscitation, especially how to prevent PPHN. And we are still in a lot of confusions about what target we achieve in preemies and term babies. And that's a never-ending process. I know you're doing a lot of research on this, and I'm sure you'll be highlighting more in the future. Any questions from the audience, please? I got one question. what's your take on generally in a lot of NICUs, they use low flow oxygen, about 2 liters, 3 liters. Is it safe for these babies? Because way back, Neil Feiner published in 1996 about the low flow oxygen in premise less than 1,500 and more than 1,500. In that, even oxygen of 300 ml per minute could raise the PO oxygenation FiO2 up to 100% in a preemie babies less than 1,500 grams. And in a term baby, even a flow of 1 liter could reach an FiO2 of 100% in the nasopharynx. So what's your take on that? You're muted. Satyan, you're muted.
That's a great question. Low flow oxygen is something that's commonly used in many NICUs, including my own NICU. In fact, when we send babies home, most often they do, if they need oxygen, they do go home on low flow oxygen, somewhere between an eighth of a liter and a quarter of a liter. So the effective oxygen delivered by low flow nasal cannula has been studied by various colleagues, and there's actually a website where you can plot how much FiO2 you're giving based on the baby's weight and determine the effective FiO2 concentration. As you rightly pointed out, a baby with low birth weight and higher flow tends to experience higher oxygen toxicity compared to bigger babies with lower flow. So in these babies, my take is that as long as you closely monitor pulse oximetry and make sure the pulse oximetry is within normal range, I think you're okay. On the other hand, sending a baby home without optimal monitoring of oxygen saturations can be deleterious. We do have some babies with BPD with pulmonary hypertension where there are really no studies evaluating optimal oxygen concentrations in these babies or saturations. And in my unit, we tend to keep their saturations between 92 to 97% when we discharge them home, and titrating the appropriate FiO2 is really important in these babies. But you are right that giving 100% O2 at pretty high flows in really tiny babies can result in oxygen toxicity, and that should be carefully avoided. Periodic measurements of PaO2 might be beneficial, but in most units, we usually rely on pulse oximetry and not really go to PaO2.
And you did point about the oxygenation should be less than 0.6% FiO2, generally to prevent any major complications. So in a target
That's correct. That's correct. So what I meant to say was, if you maintain a baby decent oxygen saturations, and if you can get away with FiO2 less than 0.6, you induce less lung toxicity. On the other hand, if you need more oxygen, you need more oxygen. There's nothing you can do about it. So if the baby is really hypoxemic and requires 80% O2, you'll have to give 80% O2 to that baby. But once you start something like nitric oxide or sildenafil, if the baby is getting better, before you wean the pulmonary vasodilator drug, wean the oxygen first and get the oxygen below 60% before you wean nitric oxide or sildenafil. So oxygen is as toxic as any other substance, so try to get that number down first, below 60%, before you touch other pulmonary vasodilators.
Okay, I had a few other questions, but I think we don't have enough time.
Can I ask a question, sir?
So we'll close it. Yeah.
One question, sir. It was a great talk, Prof Satyan. Actually, one question about diaphragmatic hernia patients. You know that the European guidelines, which came 5-6 years back, the concerns about CDH management, they say that actually you can allow hypoxemia till 80%, you can permit till 80%, up to 97%, the wide range of saturation accepted. At the same time, you know that CDH patients are at higher risk of pulmonary arterial hypertension also. So would this hypoxemia push them towards pulmonary vasoconstriction and hypertension? What is the take on this? That's one. And second question is, sepsis is a very common problem in India, I'm sure, globally. And some data, some from our center has shown that septic newborns have a higher risk of having nitric oxide synthase, and they convert into nitric oxide production is higher. So that is going to help them to bring down the pulmonary pressures, or it's a different form is required for that? How does it, what's your take on this?
These are really great questions. I'll try to answer them quickly in a minute. If not, you can email me and I can answer it by email. CDH, as I pointed out, there are really no randomized trials, and this is all expert evidence. And again, it's a balance between causing lung damage versus preventing hypoxic pulmonary vasoconstriction. So the problem with CDH is that you not only have pulmonary hypertension, but you also have pulmonary hypoplasia. And so beating up the lung is something you should avoid. And that's the reason why the European guidelines permit you to go as low as 80%. But if you have a baby with CDH on saturating 80% on 21% O2, it doesn't mean that you leave them at 21% O2. You're supposed to go up on the FiO2 at least to get their saturations into the high 80s and low 90s. So that's my take on it on that particular topic. And we are doing a study in CDH with milrinone, and I have some oxygen data. Hopefully I'll be able to present that in a couple of years. Your question about sepsis really quickly in a minute. Sepsis induces inducible nitric oxide synthase, or INOS, and releases nitric oxide all over the body, not just in the lungs. And for that reason, the hypotension and shock that you commonly see in babies with sepsis is due to unsuppressed release of nitric oxide in the body, causing systemic vasodilation, in addition to causing some in the lungs. So these babies have much more profound effects of nitric oxide, very different from what inhaled nitric oxide does exclusively in the lung. So this is by inducible nitric oxide synthase, which is different from the endothelial nitric oxide synthase, which is the good nitric oxide. So that's the difference between the two. So shock and hypotension seen in sepsis is due to inducible nitric oxide synthase. And that really causes worsening of PPHN because it drops the systemic vascular resistance further below that of pulmonary vascular resistance. I think I'm out of my time, so I will stop here and we can move on to the next session. Thank you so much.
Thank you very much, Satyan. Excellent. Yeah. Thank you.
Thank you, Professor Satyan, for enlightening us on the topic. We would also like to extend our gratitude to Dr. Srinivas AR for his contribution to the session. Thank you, sir.